Good morning, everyone, and welcome to this session. My name's Louise White, and I'm going to be moderating this session with Dr. Jim Greenwood. We are both physiotherapists, and we're also reps within the National Back Pain Clinical Network. Within this 30-minute session, we've got 4 very interesting studies to hear about. And just in the interest of sticking to times, it would be helpful. What we're going to do is run all 4 recorded talks first of all, and take live questions at the end. And so just to ensure that we're getting to the right questions to the right person, if you could state who your question's for, that would help us. And we'll endeavour to get through as many questions as we can. So without further ado, we've got our first presentation, and that is by Romana Capadi, who's going to tell us about her study entitled Predictors of Analgesic Dependence Among Patients with Spinal Pain. Thank you.
Good morning, everyone. I hope you're all enjoying the event so far. My name is Romana, and I'm a research assistant in health psychology at the University of Derby. I'm going to talk to you today on behalf of my project team, Mr. Tony Bateman from the Royal Derby Hospital and Professor James Lander, also from the University of Derby, about our mixed methods research project investigating predictors of analgesic dependence among patients with spinal pain. So spinal pain is a major cause of disability and absenteeism, and it is also associated with increased stress, anxiety and depression, which in turn can increase people's sensitivity to pain and interfere with pain management through the inappropriate use of analgesics. Painkillers are often used to treat spinal pain, but substantial and sustained use has the potential to cause analgesic dependence, which is known to develop from a process involving modifications in attitudes, beliefs and behaviours. Existing research shows that psychological factors such as pain acceptance, pain catastrophizing and alexithymia, which is a personality trait characterised by an inability to identify and describe emotions, all have an influence on both pain and analgesic use. Yet to our knowledge, no studies have explored these factors combined in patients with spinal pain. Therefore, the aim of our study is to assess the influence of these psychological factors on analgesic dependence among a clinical sample of people with chronic spinal pain. We recruited participants from spinal and physiotherapy outpatient clinics at 2 Derbyshire hospitals, and to be eligible to take part in the study, participants had to meet the set inclusion criteria, which you can see on the slide there. Participants were asked to provide informed consent before completing a questionnaire survey, which was comprised of questions assessing demographics, condition-related information, pain severity and analgesic use, in addition to 6 standardised self-report measures such as the Depression, Anxiety and Stress Scale, Chronic Pain Acceptance Questionnaire, Pain Catastrophizing Scale, Toronto Alexithymia Scale, and Leeds Dependence Questionnaire, which was worded to assess analgesic dependence specifically. And at the end of the survey, they were then asked if they would be willing to take part in a short interview to talk more about their condition and painkiller use. So 106 people completed the survey, and they were predominantly of Caucasian origin. The duration of participants' spinal pain ranged from 4 months to over 40 years. And 91% of them reported experiencing severe pain nearly every day, with severity ratings ranging from 3 to 10, and nearly 2/3 also felt disabled by their pain. Most participants reported taking prescribed pain medications, so commonly weak opioids such as cocodamol and pregabalin, and 1/4 of participants reported taking strong opioids such as morphine and tramadol, and around 41.5% of them also mentioned taking non-steroidal anti-inflammatory drugs. But our linear regression analyses established that difficulty identifying feelings, which is a component of alexithymia, stress, and an interaction effect between pain severity and difficulty identifying feelings were all independently predictive of greater analgesic dependence and accounted for 66.2% of the total variance. 21% of participants indicated that they would be interested in taking part in an interview, however only 6 actually did take part in one. You can see on the slide there are a few quotes extracted from the transcripts, but people generally spoke about factors that influence their use of pain medication, reasons for increases or decreases in analgesic use, reasons for reducing or stopping pain medication, for instance due to overdose, positive experience with non-pharmacological pain control, and ways that pain and psychological symptoms like depression and anxiety influenced one another. In conclusion then, LDQ scores showed that most participants had mild to moderate analgesic dependence, with only a small number who were more severely dependent. Our findings should be treated with caution though, due to the fact that we used a clinical sample of people with spinal pain, and therefore they may not be representative of analgesic users in the general population who are less engaged with medical services. However, they do suggest that people with chronic spinal pain most at risk of analgesic dependence are those who are more stressed, experience more severe pain, and have greater difficulty identifying their feelings. Additionally, the interview data suggests that experiences of analgesic dependence change over time, depending on treatment factors. And ultimately, psychological interventions such as acceptance and commitment therapy, compassionate mind training or mindfulness, which incorporate elements specifically targeting factors related to alexithymia, could help people with chronic spinal pain discriminate between emotions and physical sensations, therefore avoiding or reducing the dependence on pain medication. So thank you for listening. I will now hand over to Mr. Tony Bateman, who would welcome any questions or comments that you may have.
Hi.
You're on mute, Louise, sorry.
Can you hear me okay?
Yes. Sorry.
Okay. So thanks very much for that. Are we moving now to our second talk, which is entitled How Effective is Physiotherapy for People with Sciatica? A Systematic Review and Meta-Analysis.
Hello, my name's Lucy Dove. I'm an advanced practice spinal physiotherapist at the Nuffield Orthopaedic Centre in Oxford and currently on an NIHR pre-doctoral clinical academic fellowship. Today I'm presenting my MSc research project. Current NICE guidelines recommend physiotherapy as a first-line treatment for people with sciatica, so I wanted to understand the evidence base behind that. We included only randomized controlled trials, and at least one arm of the trial had to offer a physiotherapy intervention. 12 weeks was the minimum time for collecting outcomes. And in order to ensure that study participants had neural involvement, studies had to include at least one neurological test, such as sensory, myotomal reflex testing, a neurodynamic test, or imaging that correlated with clinical symptoms of sciatica. Of almost 4,000 citations found in 5 databases, 23 studies were included in the systematic review, of which 9 were meta-analysed. The forest plot shown here is for the outcome of pain at 1-year follow-up. The top 2 studies compare a minimal intervention, such as GP care or advice only, with physiotherapy. Although the overall effect is minimal in favour of physiotherapy intervention, the confidence interval goes all the way to 0, indicating a lack of certainty about the effectiveness of physiotherapy here. The next 7 trials compare surgical intervention with physiotherapy, and the overall effect size shows no real difference. The meta-analysis for disability as an outcome at 1 year showed very similar results to this one for pain. So perhaps physiotherapy is not as convincing as we thought as a first-line treatment. I'd like to draw your attention to the fact that the heterogeneity of these studies is high. You can see it by eyeballing the confidence intervals of the forest plot, and the measure of the statistical heterogeneity at 74% is substantial. It's no surprise then if we look more closely at the trials and see that clinical heterogeneity is also high. Study populations differ from one another in many ways, most notably in the duration of symptoms that vary from less than 10 days to 27 months and go unreported in 6 trials. Diagnosis of sciatica also varied widely, with 63% of studies using a neurodynamic test such as straight leg raise, 68% using imaging including all of the surgical trials, and only 47% of studies using a positive neurological exam to include study participants. A risk of bias assessment was carried out. Selection bias was low in 63% of studies. Blinding of participants is very challenging in physiotherapy trials, and unsurprisingly, performance bias was high in the vast majority of studies. However, detection bias, which should be low in all trials, was high or unclear in 68% of studies, and reporting bias was unclear in 79% of studies, indicating where quality improvements could be made to future trials. It's worth remembering that physiotherapy is a complex intervention. It's not a drug that can be titrated in a measurable dose. In the trials comparing physiotherapy with another physiotherapy intervention, there was considerable variation in the treatments offered. Here are some of the physiotherapy interventions used in the trials. Some are supported by current UK clinical guidelines, exercise and manual therapy, for example, whereas others, such as electrotherapy and traction, are not. So where do we go from here? Future trials can certainly improve quality and use contemporary evidence-based therapeutic interventions. But before we do those trials, I believe we have more to learn about our patient populations. I believe a more detailed understanding of our patients will lead to more useful subgrouping, working out which patients respond best to which treatments. A better understanding of the clinical differences between patients will help not only physiotherapy interventions, but has the potential to improve pharmacological and surgical ones too. I'd like to finish by saying a huge thank you to everyone who has worked with me on the project so far. Thank you.
I think we're just waiting for Lou to come back.
Okay, so sorry about the delays there. Thank you very much. And our third speaker is Professor Nadine Foster, and she's going to be outlining an RCT protocol, and the title is The Clinical and Cost Effectiveness of Radiofrequency Denervation for Chronic, Moderate to Severe Low Back Pain. Thank you.
Hello, my name is Nadine Foster. I'm just going to share my screen. Trial. I'm just speaking really on behalf of a very large interdisciplinary trial team led by Dr. Vicky Wild and Professor Ashley Bloom at the University of Bristol, but as you can see on this slide, involves a large and interdisciplinary team. So what's the rationale for the trial? Low back pain can be localised and thought to arise from the facet joints and periarticular structures. Radiofrequency denervation is a minimally invasive procedure aimed to reduce pain by interrupting those pain signals between the median branch nerves and the brain by heating up and destroying the nerves. It is recommended in NICE guidelines for those patients who have not had adequate relief from non-invasive treatments, but there is uncertainty about its clinical and cost effectiveness. Around 13,000 of these procedures were performed in 2017-18, costing approximately £1,667 each. Subsequent to the NICE guidelines being published, the MINT trial in the Netherlands raised controversy by showing that radiofrequency denervation and exercise was not superior to exercise alone. So in this trial, patients will be screened, recruited and randomised, and the procedure is summarised in these following slides. Patients will have a first eligibility screen against detailed inclusion and exclusion criteria, and they'll be listed for a medium branch block and essentially then recruited. They'll then have a second eligibility screen after that medial branch block. If they have a negative response to it, they won't be eligible for randomisation. If they have a positive response to the medial branch block, defined as equal to or more than 60% pain relief at 3 hours, they will become eligible for randomisation. So the trial design is a 20-centre, double-blind, parallel-arm randomised control trial with an internal pilot phase to check on recruitment and some other key success criteria, as well as qualitative research and a health economic analysis. 250 patients with localised chronic, moderate to severe low back pain and that positive response to a diagnostic medial branch block will be randomised either to true radiofrequency denervation or a placebo radiofrequency denervation. On the left, the true radiofrequency denervation will follow a standardised technique that reflects best practice and agreed in a clinician workshop. And the placebo procedure is essentially the same, but the electrode tip will not be heated. Patients, clinicians, and the research team will all be blinded in this trial, and the clinical nurse will be the only person unblinded. Please note also that if patients do not experience a clinically meaningful improvement in pain 3 months after randomisation, they will be offered a repeat radiofrequency denervation using the alternative treatment to the one provided at the outset, but without disclosing the original allocation. And that's important that all patients have access to the real procedure if they have ongoing symptoms, as we believe that it's unlikely that patients would agree to take part if they were denied access to a potentially effective treatment for their back pain for 2 years. So the diagrams below here just simply describe that. If the original allocation was to the radiofrequency denervation and they don't have a clinically improvement difference in pain at 3 months, they'll have the placebo next, and vice versa. If their first allocation was to placebo and they don't achieve a clinically meaningful improvement in pain at 3 months, they will then be offered a repeat procedure, and that will be the real radiofrequency denervation. In terms of outcome, the primary outcome is low back pain severity at 3 months using the numerical rating scale, but you will see on this slide a whole wide range of secondary outcomes, as you would imagine, over a period of 2 years. So in terms of the timeline for this trial, it's currently in setup and about to begin recruitment. It's a little bit delayed because of COVID-19, but the recruitment is expected to begin in May 2021. What's key is that we're currently identifying clinical trial sites. So if you or your site might be interested, please do contact Kate Ashton, the trial manager, using this email address. Thank you very much for your attention.
Thank you, and that offers us an opportunity for all clinicians there, and I'm sure there'll be some questions around that. So the final speaker is Eliza Steen, and she's sharing the results of her survey of UK clinical practice, and this was investigating physiotherapists' awareness, knowledge and confidence in screening and referral of suspected axial spondyloarthritis. Thank you.
Good morning and thank you for joining me today. My name is Eliza Steen and I'd like to talk to you about my recently published research titled Physiotherapists' Awareness, Knowledge and Confidence in Screening and Referral of Suspected Axial Spondyloarthritis, a Survey of UK Clinical Practice. So the reasons for undertaking this research is because axial spondyloarthritis is an inflammatory condition associated with significant diagnostic delays and is commonly missed in the assessment of persistent back pain. Furthermore, it's associated with poor awareness both publicly and within the medical community, and this has been evidenced through previous research. There had until now been no previous research looking at the physiotherapy community. With this in mind, the aim of the current research was to explore musculoskeletal physiotherapists' awareness, knowledge, and confidence in screening for the signs, symptoms, and risk factors of suspected axial spondyloarthritis and criteria for referral. An online UK survey was undertaken on musculoskeletal physiotherapists, combining back pain vignettes reflecting suspected axial spondyloarthritis, non-specific back pain, and radicular syndrome, and questioning on signs, symptoms, and risk factors of suspected axial spondyloarthritis. In order to analyse the free text responses within the vignettes and to assess for axial spondyloarthritis awareness, a priori codes were used based on the NICE guidance referral criteria, and these can be seen in the top right-hand box. Guidelines suggest that any patient with onset of back pain before the age of 45 with persistent back pain more than 3 months, with the addition of 4 additional features, should be referred for rheumatological opinion. With this in mind, all the back pain vignettes were designed to include patients under the age of 45 with persistent back pain, and the 2 axial spondyloarthritis vignettes had at least 4 additional features within them. In order to assess awareness, recognition of these features was subcategorized into 4 groups, and they can be seen in the left-hand box. They include full awareness, good awareness, poor awareness, or no awareness, based on how many of the additional features were recognized in the vignettes. I'm going to present the main results of this research. However, there are more results in the published paper. Unfortunately, axial spondyloarthritis was poorly identified by respondents. Only 60% of respondents correctly diagnosed the axial spondyloarthritis vignette at primary diagnosis, compared to 94% for non-specific back pain and 80% for radicular syndrome. Of those who incorrectly diagnosed the axial spondyloarthritis vignette at primary diagnosis, 94% of them misattributed the diagnosis to non-specific low back pain. Further vignette analysis demonstrated poor awareness of axial spondyloarthritis in vignette responses assessing clinical reasoning and further subjective screening. Awareness of national referral guidance was evident in only 50% of clinical reasoning and 20% of further subjective screening responses. The graphs here show that full awareness and good awareness was demonstrated by 61% of respondents familiar with the NICE guidelines, compared to 33% of those not familiar when demonstrating clinical reasoning, and 23% familiar and 15% unfamiliar when demonstrating the direction of further subjective screening. Really, the key messages to take home from this research is that musculoskeletal physiotherapists may not be giving adequate consideration to axial spondyloarthritis in back pain assessments. Furthermore, there was poor awareness of national referral guidance. There is a need for professional education on screening and referral of suspected axial spondyloarthritis to make axial spondyloarthritis screening and referral criteria core knowledge in musculoskeletal practice, supporting earlier diagnosis and better outcomes. The survey provides a valuable evaluation and education tool for measuring and raising awareness of axial spondyloarthritis. Thank you very much for your time today.
Thank you very much. And can we have some assistance just to unmute and get the connections with the speakers for questions? So we've got 5 minutes or just over 5 minutes. So if we aim to try and get one question for each of the speakers, I think that's a good start.
That's fine, no problem. So everybody should be able to access their microphones. It's a first talk there's no speakers for the first talk available, unfortunately.
Okay. So we've got a question for Lucy. Lucy, could you not conclude that physiotherapy was equivalent to surgery, and then think about potential harms and costs? And were there any differences in the trial outcomes based on the baseline severity? And that's a question from Stephen Vogel.
Hi, thanks for the question. I think reporting on harms and costs was not the objective of this study. Adverse outcomes were very, very poorly reported in all of the trials, including the surgical trials, and some of that is because some of the trials were old, and it wasn't a requisite of those trials. The costs was not something we looked at. And sorry, what was the other part of the question? You were looking at the severity of the... Oh, I can't hear you.
Sorry, I just need to pull up the question myself again. Were there any differences in the trial outcomes based on baseline severity?
Oh yeah, baseline severity. Another element that was unfortunately poorly reported. Studies often didn't distinguish between leg pain and back pain, which made it difficult really to look at the baseline severity. And when they did report it, they would report overall pain at a follow-up point, and it's very difficult to know whether that's still radicular pain or whether that's turned into a more chronic picture of chronic low back pain. So it's really difficult to draw conclusions based on the information we had.
Thanks. I hope that answers the question. Can I ask Nadine? There's a question from Abhijit Ghoshal, who wants to know, the radiofrequency ablations typically cause pain at the electrode site, and how are you going to replicate this in your placebo group?
Well, the very practical thing that we're doing is excluding patients who have had previous experience of radiofrequency denervation. So clearly for this trial, we're looking for patients who are naive to this intervention and therefore won't have had previous experience of it and realise that they can be painful procedures. But apart from that, the delivery of the radiofrequency denervation is reasonably pragmatic, because I think we've got some other questions there about how we're delivering the intervention. So I myself, I'm not delivering the intervention, but Kathy Price, Neil Orpin and others involved in the trial have held a clinician workshop in order to agree the protocol. And as you'd imagine, for a trial like this, we don't want to unnecessarily constrain the procedure. So the level that the target nerves are the nerve to the joint and the one below. So, for example, an L4-5 lesion will be ablated at both L4 and L5. And the clinical team around the delivery of this intervention are putting together essentially what I would call a flexible protocol to allow clinical decision making in the true radiofrequency denervation. But yeah, if folks are interested in taking part in this and want to have further questions about the procedure itself, please just do contact Kate Ashton, the trial manager, and she can talk you through where the clinicians have ended up in terms of its flexible protocol.
Thanks for that. I think that explains that and Jeremy's question as well. So perfect.
So just we've got a couple of minutes left, and there's one question's come through from Suzanne Johnson for Eliza. Eliza, can you just explain or outline how many respondents you had within your online survey?
Hi, yeah, so we had 132 usable data sets. So obviously this isn't a huge number and can't be completely representative of the whole kind of physio community.
Okay, thank you very much. I think that, Jim, I think perhaps we need to conclude this session for just now, and there's another half an hour coming up with some further talks. Thank you very much for some excellent talks and feedback. I'm sorry we didn't have time to go through all the questions, but they should be available on the chat. Thank you.
Thank you all. Just to let you know, it's just going to take about a minute or so to set up the room for the next session.